I'm sorry for messing up the schedule. Unfortunately, I have another lecture in the other hall just 10 minutes from now. So as I was saying, this is the two techniques, CT and MR, are basically complementary to each other. The problem with CT is very different because CT is widely available and it is suddenly becoming the flavor of the season and is much abused than used today. So what are the messages that I have for you today? I'll try and be as concise as I can to tell you how best to avoid misuse, abuse of CT coronary angiography and how to avoid making mistakes. So these are my pretty much 10 commandments in terms of avoiding mistakes in reading or performing or reading a CT coronary angiogram. We will quickly go over one by one. So the first important thing in a CT coronary angiogram is getting it right. What does it mean? It means that you choose the right patient and you do it the right way. Because if you do it in the wrong patient or do it the wrong way, you are going to end up with a wrong report. So the first commandment is make sure that there is a clear indication for CT coronary angiogram. It is not a screening test for any and every patient. There are selected indications for CT coronary angiography and you should restrict yourself to choosing those patients. Once you have chosen the right patient in terms of indication, important thing is the patient when he goes into gantry, there are certain steps that you should make sure. Avoid cardiac stimulants. If the patient has had a cup of coffee or a cup of tea an hour or half an hour before the CT, you are going to end up with a very fast heart rate. And that's going to be detrimental for an optimal CT angiogram. Patients who are on calcium channel blockers are another big challenge. So make sure that appropriate drugs, appropriate stimulants are avoided while the patient is taken for CT coronary angiography. Generally, it's a very good idea to give a small puff of vasodilator just before the acquisition of CT. And sometimes, depending upon the equipment that you have, you may want to choose reduction of heart rate. The current generation CT scanners do not need any monitoring of heart rate, but the older generation CTs, you may want to give some form of beta blocker or regulate the heart rate. The scanogram, you should make sure that you begin just above the tracheal bifurcation and go all the way to the diaphragm to obtain these images. I will not bore you with the technical details, but the two important things here, an artifact and a missed beat. These are the two major reasons why you misread an angiogram. So therefore, make sure that the patient is trained to hold breath. If the patient moves during acquisition, is unable to hold breath, you will have a missed data set. And that is many times erroneously interpreted as an occlusion. Same way, a missed beat. So these two things, make sure you see the baseline ECG. There is no missed beat during the acquisition. Once you have the acquisition, ensure that you look at all the multiple projections. Our problem is that we want to see a one snapshot, a reformatted coronary angiogram, something like this, and report on this. But never ever exclude the source images, the axial images, because they are the best way to assess the quantitation of a given stenosis or the vulnerability of a given plaque. The first thing that we see in the CT angiogram, sorry, I'm going to be having to be rushing because the time is short. Calcium score is the first thing that we see. The last time round I was here, I gave you an elaborate presentation on calcium score. Why is it important? It's important, one, because it prognosticates the patient. Two, any calcium tells you that this patient has calcium coronary atherosclerosis. And three, beyond a certain number or certain amount of calcium in the heart, doing a CT coronary angiogram is a bad idea. Why? Because it obscures the underlying lumen and gives you an erroneous report. Same way with the artifacts. I have already talked about this. I am not going to spend more time talking about this. The third important thing is that always see in multiple views. Do not restrict yourself to these reformatted views. If you have to see these, make sure that you see at least two perpendicular views before you are able to make an opinion about the presence, severity, and image morphology of a given stenosis. Familiarize yourself with the anatomy. I don't want to stress on this. All I want to tell you is that the left main coronary artery, CT coronary angiography today is the gold standard investigation. Why? Because oftentimes you will have mimickers because of spasm, because of abnormally positioned catheter during catheter angiography, and CT angiography overcomes all these, but make sure there is no overlap. Then you can have an optimal assessment of the severity of stenosis. You all know the branches of the coronary artery. I don't need to delve into all this. What is important is make sure that you have such views where the vessel is elongated, and this is possible. Why? Because in one shot, you get a 3D volumetric acquisition of the entire heart. Now you can reconstruct in any which view that you want, whether it is the LAD or the circumflex coronary artery. For the obtuse marginals, where the stenosis can be hidden if the catheter angiography view is not appropriate, CT angiography is very convenient. Why? Because I can rotate the heart in any which way I can, in any angle that I desire, and I can study whether the right or the left or the left anterior descending coronary artery. The concept of dominance, all of you know, from a right dominant to a co-dominant to a left dominant to a co-dominant circulation, depending upon where the PD is coming from. And in a CT angiogram, it's very easy to visualize these. Why? Because the septum can be very well profiled by rotating the heart in the post-processing techniques. Now, the reporting interpretation is always done in a very standard uniform manner, and that is the CAD-RAD score, and this is universally accepted across the world. When you mention a given score, any reader can understand, because this is objective wise and practice across the world. So any reader without looking at the images can understand and create a mental impression of what the kind of stenosis is. And beginning with the grade 0 to grade 5, we have different levels of stenosis and different clinical implications of the presence of this stenosis. I have already alluded to the concept of creating multiple views to look at the coronary angiogram, and this is exactly how the report looks like. So from different scores to different clinical interpretations is how this standard uniform reporting standard which is used across the world. Now, just a few words about the other aspects of CT coronary angiography, one of which is the looking at the or identifying the vulnerable plaque. We talked about this the last time around I was here. So we try to identify in a CT angiogram the presence or absence of a vulnerable plaque. Why? Because this changes the prognosis. This changes the way we will treat this patient. And CT angiography today is almost the gold standard. Because it is not the gold standard, there are other ways to look at it, which are better, but they are more invasive, more expensive, and not easily available. This is perhaps the most easily available, and as you can see, there are 4 very characteristic signs which identify the plaque as vulnerable and prone to rupture or create an acute coronary syndrome. Cine angiography was the way to assess coronary, the function of the heart. Today, the current generation scanners, as I mentioned yesterday, the CT angiography can very well assess the ventricular function as well as the myocardial perfusion. So this is what MR was doing, but the current generation CT scanners can pretty much do the same. So you can get anatomic information, you can get functional information, and you can get biochemical information to some extent on CT angiography as well. Now, post-operative, post-CABG grafts assessment, CT angiography, remember, is the gold standard today. And the same way for assessment of within the stents, this was a limitation of earlier generation CT coronary angiographies. But today, with the advances in our ability to post-process these images, we can look beneath the stent and we have a reasonably accurate way of assessing in-stent restenosis. I showed you many examples of how structural heart diseases can be detected on CT angiography. I wouldn't repeat them today. Or now I would just try to summarize to say that CT coronary angiography today is the standard of care for selected patients with coronary heart disease or suspected patients with ischemic heart disease. It is a very comprehensive technique which assesses the anatomy, which assesses the function, and which also assesses the consequences of those stenosis. But the important thing is we must make sure that we do not abuse or misuse the system and report it in a world accepted standard format, that is the CAD-RAD score. Thank you so much for your kind attention.
Thank you, sir. Thank you for your excellent presentation.